Dr. Andrew Scheibe is a medical doctor and INSU board member, TB HIV Care. He's a technical advisor for TB HIV Care, a researcher at the University of Pretoria, community-oriented primary care research unit, and a consultant working for the South African Network of People Who Use Drugs and Population Services International. Andrew is going to be talking to us about implementing harm reduction in emerging settings, a South Africa case study. Over to you, Doc.
Thank you. So these are my disclosures.
Just a minute before Andrew starts, Q&A. If you could please put your questions in the app. At the end, we'll have a session for Q&A. We'll use the mics as well, but you can also put your questions in the app. Thank you. Sorry, Andrew.
I'm going to provide a little bit of the local context, also highlight some of the progress and milestones that have happened in South Africa's harm reduction scale-up, where we are at the moment with some of the challenges we're experiencing, but also some of the opportunities that lie ahead of us. So we're in a geographically and politically important part of the continent where we're integrally involved in the global drug trade. So South Africa is part of a markets for methamphetamine, for heroin, for synthetic opioids, also a producer and consumer of cannabis. Much of the drugs are often en route to European markets, but we have one of the largest domestic markets of illicit drugs on the continent. And it's also high levels of drug use in a context with very high infectious disease prevalence, HIV, tuberculosis, and other bloodborne infections. And we know that the drug use prevalence in South Africa has increased significantly. So this is data that analyzes household surveys that were done routinely and asked about people's illicit drug use in the previous 3 months. And you can see in the past 2.5 decades, we've had a significant and steady increase in adult drug use. And the context that we're in is being reflected where we're collecting data on infectious diseases. So this is from a 4-site biobehavioral survey. More of these results will be presented on Friday, but just to give you an assessment that these are the adjusted population prevalences for those infectious diseases. And you will see 2 of them are in large metropolitan areas, and 2 of them are in a more rural district in Mpumalanga, so that's the Mashashing and Mbombela lines. And you can see the HIV prevalence, and in brackets it's the 95% confidence interval, is between 1 in 3 and 3 in 4 people who inject drugs are living with HIV. Very high prevalence of tuberculosis, much higher than other populations, as high as 7% in eThekwini, and hepatitis B, similar to other populations in South Africa, but hepatitis C, from an antibody perspective, up to 90% in some of the places that we did the study. More recently, there was a report done as part of the Global Fund's surveillance and programming using a more rapid, cost-efficient methodology called the Biobehavioral Survey Lite, and it was piloted in several districts. What's interesting is these are more traditional, more rural districts, and use a combination of programmatic data and outreach data, and then pull that to give an overall estimate. And you can see in green, those are the prevalence estimates for HIV. And you'll see that 2 of these are also still in Gauteng, which is the largest province with the most population, but several of them are from more rural parts of the country. And you can see in Bojanala, for example, which is in the northwest, 60% HIV prevalence, and in other places you can see it's similarly high. So it's not just the prevalence that's a problem. We know that we have very high new infections. So from the ability now of tracking the cohorts in Global Fund cycles, there's been the ability to assess HIV incidence. And these are in populations of people who are in contact with harm reduction programs. So this is people who have access to needle and syringe services and potentially access to opiate agonist therapy. And you can see this is the HIV incidence of up to 14.9 per 100 person years. Very, very high, much higher than any other populations in our context. So we know that we have an increasing epidemic, and the modeling data that was shown and will be done for the country will put this into context in relation to the broader population. We don't have a good sense of what's happening with opioid overdose. We know that it's happening, and as we use different methodologies, we're getting a better sense of what is going on. So several years ago, there was a community-led research project assessing overdose experiences by peers, among peers. It was a small sample in 3 cities, but found that many people had experienced non-fatal overdose and knew someone who died. Subsequently, the biobehavioral survey, which I showed the prevalence data for the infectious diseases earlier, showed that 5 to 25% of people had self-reported an overdose. In the Global Fund program data, when they assessed the service providers and the people who were accessing services in 8 districts, you can see very high self-reported overdose. You know, about a quarter had experienced an opioid overdose, 40% had witnessed an overdose, but 81% were unaware of naloxone. It's very important to know that one of the risk factors for an overdose, which is fatal, is a prior overdose. So we can just see from the data that we can anticipate very high levels of opioid overdose in the current context. We also know that drug use is an issue in our correctional settings. We've had a range of research that's shown qualitatively and quantitatively that people are using drugs either in remand or when they've been sentenced. And we've seen that there are higher burdens of HIV, hepatitis B, and hepatitis C compared to the general population. You can see it's not as high as it is in other countries because only a smaller proportion of people who inject drugs are part of our broader prison population, but it's still significantly higher than the general population. Encouragingly, our policy framework is, in theory, supportive of harm reduction and evidence-based interventions, but drug use, drug possession, and drug purchase is criminalized. In the set of policies which are supportive of evidence-based interventions, importantly includes our National Drug Master Plan, which is currently under review, and there's a lot of advocacy to ensure that the good evidence-based interventions that are in there remain in the next cycle. Importantly, South Africa has a very strong HIV strategic plan that very clearly talks about drug policy reform. Harm reduction scale-up is very clearly included. We also have a strong health sector master plan, which provides a very clear policy support of opiate agonist therapy. However, it is silent, and there's no national Department of Health policy that supports needle and syringe programming, which is a major policy gap. We do have good viral hepatitis guidelines that talk about supporting and referring and access to needle and syringe services and opiate agonist therapy as part of hepatitis C prevention. Our National Essential Medicines List Committee is currently reviewing methadone for putting it onto the essential medicines list at primary care for opiate agonist therapy. I'll talk about in a moment what needs to happen for that to scale up, but that's a really positive indication. However, we do have some conflicting policies, and there are some unclear policies, particularly that come from the Department of Social Development, that don't speak about opiate agonist therapy or overdose responses or needle and syringe programs, and there should be harmonization. We're fortunate enough to have a very strong civil society and a strong community of people who use drugs. I think you've been exposed to many of the leaders in this field. The community were involved in some initial research about the effects of drugs and drug criminalization as a report called Everyone Looks at Us Bad, and it was done to inform the current drug master plan. So it was done about 2016. Also, there's been some community-led research done by women who use drugs among the effects of drug use and drug criminalization among women. And more recently, there's been the establishment of local and a national network of people who use drugs that have strong links with the regional and the international network of people who use drugs. One of the current areas of development, and there are many of those leaders in the room, is to try and establish and formalize a sector within the civil society structure of the AIDS councils for people who use drugs. So currently, that would then enable people to be actively involved in policy processes and also then be taken seriously and be invited to engagements that inform the policy. Historically, there was no inclusion of people who use drugs, except in the Global Fund CCM, which has been a very important mechanism for advocacy in our country. And we are still working to get people who use drugs to be included in our national coordination structures. We have problematic coordination structures. For example, the Central Drug Authority, which is responsible for coordinating the response, does not allow people with lived experience to be on the board. You have to be clean for several years with 3 psychiatrist letters, which is completely against the principle of working with and for people who use drugs. That is very problematic as the coordinating structure for our drug response. Our current situation is our financing for harm reduction is overwhelmingly relies on donors. The Global Fund is the major contributor for the harm reduction program and harm reduction scale-up. This is the data for the current GC7 period, and so you will see for the people who use drugs program that's been allocated is $16.7 million, but that's only 4% of the total country envelope. And you'll see the targets that are currently set are to reach about 26,000, almost 27,000 people with needle and syringe programs, and almost 5,000 people with opiate agonist therapy across 8 districts. Just to note, there were an intention to scale up the Global Fund program as part of the request for funding, but because of financial constraints, that is just not possible. We are fortunate enough to have been receiving US government funds through CDC. They've been supporting 2 districts. There was a stop work order that was in place temporarily, and that was then reversed, but currently it's uncertain what the future of PEPFAR funding through CDC will be in South Africa. We have one very good example of domestic financing, which is funded by the City of Tshwane Metropolitan Municipality, so local government. It's now on its second cycle of funding. It started in 2016, and it has 16 sites across the district that provide opiate agonist therapy, needle and syringe programs, and psychosocial support. It is the only example of local funding, and it's really wonderful to have a representative from the city here today, so thank you for joining us, Mr. Nkoko. We do have a few other good examples of practice. There's been a Global Fund transition period, so some of the sex work services have stopped operating, and we, in the previous cycle, started integrating needle and syringe programs for sex workers. And in one of those districts, which is in Lejoela-Putswa in the Free State, they managed to get an MOU between the District Department of Health and Guardian Angels, which is an NGO, to get needles and syringes. So it just shows you it's not a policy, it's a political will issue, because that district has shown you can get needles. Similarly, the Eden district in the Western Cape, there's a small NGO that's running an opiate agonist therapy program and needle and syringe programs, getting commodities from the District Department of Health. We also have some other donors that are supporting advocacy and strategic projects. We are a country that is a leader in evidence generation, and encouragingly the literature base is improving around the issues affecting people who use drugs. We now have several rounds of biobehavioral surveys. There's a lot of qualitative data that understands and provides insight in some of the challenges in facing people who use drugs. We've now done some strong programmatic evaluation of the Global Fund program of opiate agonist therapy, showing its effectiveness of improving uptake of HIV treatment and of improving access to HIV testing. And as we saw through the programmatic assessment of the cohort analysis, the protective effect of access to OAT on HIV risk. We also are improving the ability to document the benefits of needle and syringe programming. We're working with various partners to develop some models of the impact of the HIV and hepatitis C epidemics in South Africa, and really what needs to happen for scale. This is an encouraging picture of what's happened with our needle and syringe program since 2016. You'll see the number of sites has increased to currently 10. This is data that's reported as part of our surveillance called Sekendu. And at the period between January and June this year, just under 35,000 people were accessed with needle and syringe services. We have a similar positive scale-up in our opiate agonist therapy program. Initially started with 1 pilot. We now have it in 11 sites. This is just the data from Sekendu. You can see it's 10 sites with just under 4,000 people on opiate agonist therapy at the end of June. We do have some excellent examples for the world around when starting opiate agonist therapy, that it should be integrated that it should include take-home doses from the onset to try and decentralize initiations and continuations. And also we're working with some partners that have done some pilot naloxone distribution, which will also be talked about on Friday. The Department of Health is in the process of starting an opiate agonist therapy pilot in 2 community health centers that will inform the essential medicines list placement of methadone on the EML, which will really integrate it into our primary healthcare setting, which will result in sustainability if the pilot is successful. Our Department of Correctional Services has been very encouraging in their response to harm reduction and are piloting an opiate agonist therapy program, probably starting before the end of the year. Peers are involved in many aspects of the program. Community monitoring has been done to inform the programs, and there has been a national directive from the South African Police Service in support of harm reduction. But we have a far way to come. This is an example at the population level. If you remember what Ern said, we mustn't think too much about the 300 needles per person per year. People need as many needles as they need. But essentially, to get at that global benchmark, our needle and syringe coverage, assuming our current population estimate and no population growth, has to increase 3-fold. Our opiate agonist therapy, on the other hand, has to increase at least 13-fold for population impact. So at the current levels, we're not going to achieve epidemic response, epidemic control with HIV. And we're seeing this in the data that's being modeled. We have a range of challenges. We have high levels of stigma. We have limited choice. We have some community resistance to needle and syringe programs. And in terms of opiate agonist therapy, there are many health, social work, nursing professionals, pharmacists that do not understand opioid dependence and do not understand harm reduction. There are lots of myths about it, and we've got no local production. In terms of opioids, we've got very limited awareness around opioid overdose, how to prevent it, how to manage it. We have restrictive policies in relation to naloxone. It requires a doctor's script, and if you are an employee, you cannot inject someone, but we can give it to peers with scripts, and so we have the mechanisms, and we need to use them. We have poor surveillance of mortality and of overdose, so that's an area of work. And in terms of stimulant harm reduction, we have a huge stimulant using population in South Africa that have many health concerns, particularly mental health concerns, and we have very few harm reduction interventions for them. We have a range of opportunities from a policy and leadership perspective. We heard a very strong statement from the Minister of Health. Hopefully they will commit and support scale-up of harm reduction. We hope that the current legal reviews that are being considered around our Criminal Justice Act will consider alternatives to incarceration, and also the work for drug policy reform will continue. From a service delivery perspective, we need to improve our integration. We have to focus more on women who use drugs, young people who use drugs, and also chemsex. In terms of the medications, we need simpler pharmaceutical policy that allows multi-month prescribing for people who are stable. We also need a pharmacy policy that allows the use of a single bottle for multiple people. We currently have to have a single bottle per person, even if they're on daily dosing, which is very inefficient. We need local production. We need long-acting formulations. We need to train our healthcare force, and we need sustainable financing. So in closing, drug use and injecting is increasing in South Africa. We have an HIV and hepatitis C and overdose epidemic. There has been scale-up, but it is nowhere near the size of what's required for control. So South Africa really has the potential to be a leader in this area. Thank you.